What led you to expand beyond the US? Why did it work? What were the challenges? And would you do it again?
Yeah, I think youth and hubris is probably what led us to do it at Neuromatrix. What I learned from that is that the problems of healthcare, the delivery, the diagnosis, the treatment, the engagement, and the healing of a patient are universal and don't depend on boundaries. Working in Europe with Helios, which is the mental health company, European borders look a lot like state borders, as do the rest of the world. In the US, we have some widely variant regulatory frameworks across the states. Louisiana, they have their own laws. So, when you start to think about it that way, same thing exists in Europe. The things that we can teach each other. That's, global health. It's a time as arriving on the stage. You're seeing large funds like Ares, KKR, and Bain talk about carving out a global health segment.
All right, welcome to the next Scale Community Technology Innovation and Healthcare podcast. I'm joined today by the CEO of US Heart and Vascular, Robbie Allen. I've had a pleasure of working with Robbie across several of his organizations, and Robbie comes from a C-suite and board executive across many different parts of healthcare, again, today with US Heart and Vascular. So I'm really looking forward to the discussion. Robbie, welcome to the podcast.
Thanks. Happy to be here. Appreciate it, Jason.
So maybe for those who are less familiar, we can begin with just a quick overview of US Heart and Vascular in terms of your areas of focus, your footprint, and just where the business and company is today.
Yeah, happy to. So US Heart and Vascular is it's an MSO in sort of cardiology, CT surgery, vascular surgery. So if you think about kind of all three of those specialties, we have all of them inside the platform, physicians of each of those specialties. We have the practices, the cardiology practices themselves, and then we also have heart hospitals, ASCs, and kind of the joint ventures that go along with that. Generally speaking, across the I-10 core. So if you kind of drive down I-10, it's all of those states minus currently Florida and California. Nothing against those states. It's just largely we have not been in those two states. And we go a little bit north as well. So fairly geographically contiguous in those states. I think kind of 400 and change providers, mostly concentrated in the cardiology space. I would say 10% are in the vascular and CT surgery space, which is roughly the breakdown of procedures across that grouping. From the patient standpoint, though, of the 1,000,003, 1,000,004 patients that we have, it roughly breaks down that way. About 150,000 are in the vascular and cardiovascular surgery space.
In terms of your footprint, you mentioned 400 providers. Is it 5 states that you're in today?
We're in 6 states right now. So kind of the biggest concentrations, if you want to think about kind of geographic heat maps for a number of providers, we're very much the largest thing in Texas in the cardiovascular space. And I think we're either the largest or kind of an equal player in the Arizona market. So when you think about that, heavy concentrations of providers there. From a numeric standpoint, from a kind of relative scale of the market, we're quite large in Louisiana and Alabama.
Mm-hmm.
And I would say in parts of Kansas, we're also kind of have what I would call significant presence. Is maybe the better way to say that now.
Give us a sense for how much the company has grown since it was formed. I know you were not there for the formation, but either since you started your tenure, or since the formation, if we were to compare the 400 providers today, what did this look like at formation? If we were to compare the number of ASCs under management, what did this look like at formation?
Yeah, that's a good question. At formation, this was not quite 40 docs, one state, one ASC. And so that was about 3.5 years ago. I joined about a year and a half ago. So joined kind of not quite 2 years into its tenure. Since that, so we've kind of 10x the scale of the organization. We now have about 15 ASCs. Several of those are JV'd in different structures. Generally speaking, we are not JV'd with hospital and health systems. One of the premises of USHV is to move heavily into risk-based contracting. And so the HOPD rate structure, while temporarily good, and a JV is generally not something seen as a positive in value-based care arrangements, right? It tends to be much higher. So those JVs are generally carefully architected. But that growth has come through acquisition, through de novo, sort of placement of new practice locations and new practices in their entirety, as well as sort of organic growth of the footprint or kind of the natural spread of each of those areas. We're still pretty acquisitive. I mean, the growth at this point, we will still acquire somewhere in the 5 to 7 practices a year range. those practices now tend to be smaller. There really are no large practices left except one in Virginia. So now those practices tend to be much more accretive to market. They tend to be much more targeted and less kind of greenfield expansion into a new state for opportunistic reasons. So we tend to be much more thoughtful about that. But I would say we're probably the most acquisitive company still.
You mentioned de novo. Were all of those ASCs inherited through acquisition, or were any of those ASCs developed de novo?
No, a little over half of those are de novo development that we've done. So we actually have a fairly significant department that does just that, stands those up, makes sure that they're kind of well equipped. We've hired some really high level talent. Angela Durham heads up that division, came out of AmSurg for a long history there, and some consulting work as well. But that division is kind of key, particularly, I'm sure you're aware, we're all kind of anxiously awaiting the July report out of Medicare on whether ablations are allowed to kind of move into the ASCs, which is a huge cost savings to the system if they do move into the ASC, like almost an 8x cost reduction when you do an ablation in the ASC versus the hospital.
I love the cardiology space, so I'm really excited for the next question and your response to it. But I think there's so much going on in the cardiology space in terms of movement to outpatient. I think there's a lot of innovative work in the value-based care space in cardiology across your organization, some of your peer platforms around the country. And one of the recurring themes that I love to ask CEOs is, as you've scaled, as you've gone from 40 providers to 400 providers, so 10x in 3.5 years, how has USHV leveraged its resources, scale, expanded management team to create differentiated care on behalf of patients, on behalf of the healthcare system? How are we as a country better off with the USA of today versus the fragmented network that you would have represented 4 years ago?
Great question. That's the right question that I think all too often gets left out of the mission on these things. We're passionate really about a couple different things. It's kind of our core values are three things, right? Expanding access to care. And we're doing that in every market we're in, not just in the places with $1 million homes, because when you're talking about population health, if you want to get ahead of that and actually take the attributed lives you have and manage them well, you have to go to places that aren't always kind of obvious to sort of stand up capability sets. The other one is to reduce cost of care to the system. We're doing that in kind of three ways. One is the obvious, let's prevent care that is unnecessary by keeping people healthy. And so one of the biggest ways we do that is kind of reach into people's lives and homes, remote programs that were not available to these practices without the scale to do that. Sort of 24-hour, you start here when there's a problem. That's probably been the single biggest thing from a patient experience standpoint. So when you look at integrated care clinics, those patients love that experience. There's a lot of touch points. They're engaged. It's also significantly less expensive. We reduce admissions and readmissions by significant margins. But as you think about that, and as you think about moving site of care into the locations like ASCs that are lower cost and generally speaking, almost always enjoy higher NPS, patient experience, physician experience, staff experience versus a hospital, particularly in the places and hospitals known for cardiac care. Those are largely Byzantine kind of structures that take a long time to figure out how to park and where to go. Figure that in there. And then the last one is the technology that we're able to bring to things that are as simple as patient engagement and check-in and interaction in an office and an ability to kind of work with people on appointment times, locations, the scale and breadth of, hey, I notice you live in this part of Texas. You have an office right there. It's 5 minutes from your house. Would you like me to see if there's a location there? That's pretty meaningful for a lot of people. And it just begins to sort of change the equation of, hey, we're not likely to make going to see your cardiologist as much fun as going to whatever your choice of entertainment venue is, but it can certainly be better than sitting in an office waiting for an hour for the door to open, which is the last piece of what we're now in the middle of trying to work on meaningfully, which is no patient sits in a room waiting on somebody to come in. And so we do that by shifting the structure of how people engage with the patient when they come in and how the team tends to, and we use the team approach, tends to engage with that patient. And where we do that really well right now, patients have a very different experience of the visit.
So investment in ASCs at non-HOPD rates, the integrated care clinics, which involve care outside of the confines of the office, getting into the patient homes, for example. And is that home care or is that virtual care?
Both. So we're in the middle right now developing kind of that last mile of home care one-on-one in person. virtual care we currently have now, and we partner for the home care. The question, I think, for all value-based care, really, when you really get down to the nuts and bolts of what works and what doesn't, for the high acuity patients, you have to cover the last mile in person. If you don't have that, it doesn't work.
And then investment in technology, it sounds like around the patient experience primarily at the office. Is that fair to say, or is it technology remote care as well?
Both. Yeah.
Oh,
Yeah,
so
absolutely.
so on average, a lot of new service lines, new investment, and on average, relative to other stakeholders in the market, perhaps a lower average reimbursement, right? At least relative to the hospitals.
That's right. Significantly less.
The question I have is to afford that. What's the missing piece? Are you taking alternative reimbursement models, risk-based models that allow you to do that, or are you doing all of this in a fee-for-service environment today?
We've taken a slightly different approach to how we do value-based care. I think we we do use risk models, and we have to live in a fee-for-service world. And particularly when it comes to specialty care, the historic way of doing value-based care, which is go get $500 million of funding, make a giant bet, take all the attributed lives, and a year and a half later, hope that you've saved the healthcare system 200 million and you get half of that. And
Mhm.
very often, I think what we found out is you saved them none and you owe 50 million. That is something we purposefully stayed away from. And in cardiology, I think you actually have the ability to begin to build a ladder from what fee for service looks like with very definable steps into kind of totally attributed risk. And those latter steps include things like meaningful shared upside, which in primary care is $1 a patient. Whereas in cardiology, if I stop a heart failure patient admission, I can save the system $25,000. So suddenly the pot of what you can save looks real,
Mhm.
all the way down to kind of subcapitated arrangements on management of or integrated care clinic style management of diseases like AFib and heart failure in particularly, which tend to drive huge spend. So as you think about it that way, we're building a ladder of that generally drives savings to us that we share. The other things, though, that we do are we get much more efficient in how we deliver care. So, even in the fee for service infrastructure, when you think about traditional cardiology, very often, if you have never had the experience of being a patient, and I have been, there's a ladder of testing that goes on inside of a
Mhm.
cardiology practice. And it's kind of this sequential escalation of tests, but kind of everybody gets an EKG, everybody gets an echo, and then you kind of start going up the ladder. One of the things that we've been able to kind of study and produce results on is what happens if we kind of skip all that in many instances, not for everybody, but in patients where all the indicators indicate there's some acuity of disease here and go to maybe advanced imaging in that case? What happens then is we do way less CATs from a diagnostic standpoint, and we skip the ladder, and it actually saves the payers money.
Mhm.
So we're spending less, but it opens up the schedule. And so on a per encounter basis, that can look like on a fee for service basis that you've made more money in that case on that patient, but it's not on a longitudinal basis. And so what we're doing is shifting the mix of what you see in the office so that the bigger brains in the office are doing the higher acuity work. And that in and of itself tends to provide a reimbursement environment that works better for the providers, as opposed to kind of just churn of the regular stuff.
So you've built a strong foundation and arguably a better mousetrap here within the cardiology spectrum of care. Let's talk about health equity for a second. And I think one of the things that's interesting about USHV is if I look at your geographic dispersion, you're in states that aren't necessarily at the high end of average income and aren't necessarily at the high end of average outcomes from a healthcare perspective. And it's a big topic, right? There's a wide disparity at a state level across the country. And so how have you found that dynamic of investing in additional services programs relative to getting that foundation out to a broad spectrum of patients across a different payer mix, commercial, Medicare, Medicare Advantage, Medicaid? Are you primarily focusing on commercial, or are you also seeing these non-commercial patient demographics?
No, in fact, we're working with Medicaid, with Medicare, CMMI directly. Um, Part of the benefits of cardiology, and I think you know this, because cardiology always viewed itself as a Medicare specialty. Traditionally, the bulk of your patients were older. You tended to kind of think of Medicare as the driving rate, and many markets, indeed, even the commercial rates approximate Medicare. It makes it easier to do what we're actually doing, which is stepping into markets that often are underserved and have poorer outcomes, as you point out, on a sort of a population health basis. But it's also where you can really move the dial.
Mhm.
And so in a specialty where Medicare and Medicaid are kind of collectively your largest payer, if we also include Medicare Advantage, by a long shot, 60 to 70%, depending on the market. In some places, 80. It lets you go into those markets. And that's kind of where we began to think about this is we can actually go in and really significantly move the dial on the disease and the population health in a place like Southern Louisiana, where heart disease is incredibly prevalent across demographics from a much younger age. And those are the kinds of things that get people in population health and value-based care pretty excited. It's kind of long been my passion to look at the underserved health equity aspect of this and say, how do we change that? How do we not just make this beneficial to people who make a lot of money and can go anywhere they want? How do we take this and significantly change the equation? Because that ultimately is the only way that you're going to stop the bleeding on US healthcare spend. You're just not going to be able to do it any other way. And everybody in the group, I mean, I'm sure there are outliers that would just prefer to be in the old world of fee for service, but the group joined together around this concept. And so there's a pretty tight alignment around it. And that's where I think we're, if a central mission to what we're trying to do, that's where I think you're starting to see USHV as a team kind of come around that and say, how do we get these numbers? How do we make it work? And how do we start to really share this process? Because it does no good if we're the only ones doing it, right? And I think our peers are aligned on that as well, by the way. We work
Yeah.
with a kind of a coalition around that.
So I want to position USHV as part of a solution or a helpful sort of catalyst in terms of the proliferation of high quality, low cost care to underserved markets. So I'm sort of making that up as I'm hearing the feedback here, but it's consistent with what the conversation and what you're saying. And so I want to go with that for a minute. I want to think about USHV relative to other players in the market. So relative to the fragmented smaller players, I think you've already covered that point. You've made the point that there are service lines and investments that need to be made, and hard to do that without sufficient scale and investment wherewithal. Relative to the hospital players, you mentioned about HOPD rates, and so you're a lower cost of care. Are there other reasons why doing what you're doing in terms of getting that type of a care program into these underserved markets would not be as easy for a health system to do? Or is it primarily that you're able to do it at a lower cost?
I think for health systems, the bigger challenge, particularly in rural and underserved markets, is they're so thin on margin if they're positive at all, that the ability to think outside the box on, for example, site neutrality. Site neutrality terrifies basically half of the hospitals in the United States in any version of it because they're running at a 0.5% margin and they can't invest in thinking alternatively about how to provide this care. That said, there is pretty strong interest, and we are not against the health systems. We actually try to find ways to work with them. Perversely, they're very incented to get the admission, but they're very incented to not have a readmission. And so that's just part of the perverse economic consequences of the way the system works today. But by working with them on the readmission, using the very same tools we use to prevent both, we're able to kind of help both do this, but they can't do that on their own. They just don't have the resources in most markets. There are progressive systems that are starting to think about that and saying, hey, we need to get ahead of this. How do we work with kind of large syndicates of take your pick, primary care, specialty groups? They're generally not in a position to invest. The large nonprofits are doing it, Ascension Healthcare, folks like that kind of get to take advantage of a little double dipping on both sides of the equation, sort of the tax free and the nonprofit and the HOPD rating. But they can't do it in rural markets. They're not in those markets, generally speaking, and they're not by choice.
Yeah, I mean, a couple other points. I think the low margins is one. I think that the specialty focus is another. I mean, I've had a chance to speak with CEOs of large specialty organizations, and every one of them, I'm always amazed to think about how much they have developed within their core specialty to achieve excellence and what it really takes to get to those outcomes. And it's that fully integrated stack within cardiology, within orthopedics, within oncology, whatever the specialty is. And it's hard to imagine a multi-specialty player, which is essentially what a health system would be, in a site of service, achieving that type of program within every one of the specialties that they touch. And so it's much easier to imagine a partnership between a health system and a network of specialty players that focus on those markets.
You're calling out that. Yeah, that's right.
I also think that you bring best practice laboratory from across the country. And so the ability to not just build out that stack, but make comparisons across different markets is another unique attribute. And I think a third piece is that you're probably, and I can't speak to every health system, but on average, you're probably more nimble than a health system. And so to get into some of these underserved markets is perhaps easier for a business that's not encumbered by large facility footprint. So I think again, it's a great partnership opportunity, but I think there are some unique advantages that these specialty MSO players that execute well have relative to a health system. One more question before we sort of talk about the cardio landscape more broadly for a second. So one more question about USHV. As you look forward over the next 5 years, what are you most excited about? We've seen large MSOs that have moved from being acquirers and employers of physicians to build clinically integrated networks within their specialty. We've seen large MSOs move internationally to pursue expansion and growth outside of the US, strategic partnerships, risk based reimbursement, partnerships with hospital systems, which is, again, gets back to strategic partnerships. So, what is the next transformative growth opportunity for USHV that gets you excited beyond, the continued add-on acquisition?
Yeah, I wouldn't say add-on acquisitions excite me in the sense that they kind of happen whether or not we're doing anything. But I'd say three things. We believe medicine's a team sport deeply, and I think you just kind of highlighted one of the primary reasons why we can be more agile in a single domain. I think the ability to partner in new ways with different players in the ecosystem of healthcare is what's really starting to become interesting. That's piece one. Piece two is that we're seeing an enormous push, a recognition of you can't keep doing it the way we're doing it forever. It's almost like oil, right? At some point we will run out.
Mhm.
So you got to have the plan for how this is sustainable beyond that point. That piece is coming faster and faster. And actually, that excites us. It's kind of core to what we're trying to do. But the piece that I think is really that's likely to change the world as we know it and everything we're doing is this integration of finally meaningful and assistive technology that's starting to help. And it's easy to kind of label that AI. I tend to see AI very differently.
Mhm.
And I think our group does as well. We see it as relieving a lot of the diagnostic burden, actually. Not saying I want to replace providers, that's not the point, but providers today generally value themselves on their ability to kind of call the diagnosis. Differential diagnosis is a large language model problem. I mean, it is squarely in the standpoint of really making that operational. By doing that, it lets us become healers again,
Mhm.
lets us engage the patients again, and it lets us begin to turn the paradigm away from the sort of sick care system into how do we make this about something you want to do and something that keeps you as integrates into part of your own fitness and health and wellness routine. That those three things together sort of combine to things that get us excited. There's certainly market expansion opportunities and things like we've looked at places in Europe and other places as well. I think it's probably a couple of years off, so that may be sort of the end of that 5 year time horizon. But that's what generally gets me pretty excited about this phase.
Have you started to work on those three initiatives? And would you give yourselves, high, medium, low confidence on making meaningful inroads over the next 12 to 24 months on
On
those?
technology, yes, I would give us, we're knee deep in investing in all of those. Not so much, I would call, well, we are actually working on the diagnostic side, but putting in meaningful technology that is empowering to the providers. I mean, I'm not just talking about the escalating war across the fence between payers and AI agents doing the negotiating, but the actual things that involve clinicians. We are heavily invested in that. I would probably give us, we're in the front of the pack of runners on that one. When it comes to thinking through the other two, I think we are investing in all of those areas. I would say we're probably middle of the pack on those. We've spent this year, just to give you some color, nationalizing our EMR on a single instance, nationalizing the entire tech stack so that the entire company sits on a common set of systems. We believe that's kind of key and foundational to being able to do anything at scale. And I would say that has taken an extraordinary amount of resources. And so that's next phase is all those things we just laid out.
I want to get your perspective on the national cardiology landscape. So there are a few players of scale within the cardiology space that have grown as a meaningful footprint, and I I don't know if this is true, but to my knowledge, there's not much overlap geographically. You kind of have maintained your separate regions across the country, and I'm wondering as you look out over the next couple of years, what the landscape looks like. Do you sort of maintain separate regions and really focus on building out value-based care platforms in those regions and dedicated player per region? Do you see consolidation amongst some of these larger players? Do you see encroachment and you start to compete more head to head? Or do you see us going in a totally different direction where some of these players will merge together with other specialties rather than be pure play cardiology players for the next couple of years? So what's your projection of where the market goes? I know it's a hard question.
Yeah, I think you're seeing a little bit of it. I mean, when you think about cardiology as a whole, about 18% of cardiologists aren't employed by a system or something like that. So, by the way, it was the direct opposite of that 20 years ago. So it was a significant rate change that kind of drove everybody into hospitals by force or necessity in most cases. That paradigm creates it's a little bit, it's really functionally unique among specialties, has created this pool of large group of cardiologists that want to come out of health
Mhm.
systems. They kind of went in under duress. What's the opportunity to come out? What does that look like? Until recently, there wasn't really a good landing space for that. I think that's probably the single biggest change you're going to see is some peel out of folks out of systems, particularly. I mean, for example, if site neutrality came into effect just on the office subsidy, in other words, that office visit subsidy that you get when you become part of a health system, that would make it almost functionally economically not viable to employ cardiologists as a health system. And so there are some forcing functions sitting out there. But to the what I think is the underlying point, you're starting to see discussions of consolidation. There's really only three MSOs of scale. Everybody outside of those three is kind of sub 50 providers and
Mm.
highly regional. So as you think about that, and only two of those are working meaningfully on value-based care. So when you think about it that way, you've got two that largely have minimal overlap. Arizona, Florida, and Louisiana are the places that these MSOs tend to overlap. So I think we're the only group that overlaps all of them in those two areas. It's such an underserved market that I doubt competitive market share battles are in the near future.
Mhm.
What instead I think you're seeing is like we've come together largely as a coalition around some of the value-based care initiatives with CMMI to say, hey, this shouldn't be one of us. We should do this together. And so we should, because this is something that's going to benefit humanity, let's go get it right and let's all do this together. I think you're going to see that. I think you're going to see some of these smaller players who have run up against sort of a wall of growth capability. Single state guys, think, the folks that are in the sort of 20 to 40 or 50 providers that are 3 and 4 and 5 years into their hold cycles. As a rule, I think you're going to see those guys come out into one of the others. And you're seeing that discussion start to play out in limited fashion around the country. And you're seeing less irrational competition. One benefit of kind of 22, 23, and 24 is interest rate shift and paradigm is you're seeing significantly less irrational behavior by MSOs when they partner with people. You're seeing multiples look more um, financially viable over the long term. It sounds great to get a 20x on your 10-man practice at a 50% scrape. But the realities of that, as you try to put together a business that has longevity, while that may have benefited the investment banker that sold the practice, it doesn't actually benefit the market, cardiology, or kind of the end game. And so you're seeing that go away, which has sort of made the environment right for things like MOEs, mergers of equals or mergers of kind of arbitrage mergers of equals that are coming together. Hearing lots of talk about that. Um,
It's interesting. So you've got sort of a confluence of variables that actually are conducive to building great businesses that compete based on the value that they bring to the market rather than just deployment of capital. And so you've
exactly.
got a organic embedded growth opportunity as physicians migrate out of the hospital system, which is unique to cardiology relative to many other specialties. Relatively small number of scaled players in the market. Opportunity within value-based care that requires investment in building sort of these holistic offerings, force you to think about really developing your business. And so you've, instead of focusing on direct head-to-head competition, actually are collaborating, it sounds like, with your peers on advancing the market. So it's wonderful to hear. And I wonder how many other specialties that's a similar dynamic versus not. Do you have any thoughts about other specialties that follow a similar sort of trajectory, or is this truly unique to cardiology?
I mean, I've had the privilege of working in quite a few specialties, and when you think about the ones that are very similar from a scale size and market, GI, very similar size specialty, neurology, also a very similar size specialty. You think about specialty orthopedics, not general orthopedics. very similar size bucket of things. I would say that those have been much more competitive environments, particularly GI. And like when you think about ophthalmology, dermatology, and specialties like that, highly competitive. Much more interest in the space, less connected to health systems. I think one of the things that's unique in the cardiology space is that hospital dynamic that's relatively recent, that's allowing folks to be agile in a market without kind of oppressive competitive market share forces that are constantly going on. And it lets you then get creative enough. You can be effectively good for all time zones with the people in your market and work through the challenges that folks generally kind of have not been able to invest in those other specialties. There are plenty of examples of folks who have in all those specialties I just listed, but it's been slower to come around. So like you think about Hopco and the orthopedic space and some of the stuff they've been able to do creatively largely is depended on their what I would call captive markets. And they're a bit, they have a few that they enjoy no competition,
Yeah.
which is rare.
So I want to ask a question related to this about sort of the legislative environment. Here's a business that is, again, doing a lot of good, bringing high quality care to underserved markets at an average lower cost, and really focused on building out a structurally differentiated platform. There's been a lot of noise in the market about legislation coming down primarily at a state level. But also we see legislation, Medicare changes the way that they reimburse periodically in their value-based care reimbursement programs, which can create confusion and noise. So we've heard that as well. But, California, Oregon recently passed, what is it, SB 951, creating sort of barriers for MSOs to operate freely. How does that factor into decision making in your organization, if at all? Are there states that you're avoiding as a result of that? Does it make it hard to invest with uncertainty, or your sort of bet is that, high quality cardiology players, there'll be a place for you and that's what you're building. And so your head's down, irrespective of some of the legislative noise that's out.
It's a great question. I never would have imagined I would spend as much time on state level lobbying and legislative monitoring as I do today. A couple different aspects to that answer. One, I spend a great deal of my time paying attention to engaging in lobbying for not so much binary solutions to these states. These things are coming in place, not just Oregon, which is in some ways not surprising to see this type of legislation in Oregon and Vermont and places like that, but Texas, for example, which with the current dynamic in today's political environment where the right is generally much more populist now and the left is maybe disorganized is the right way to describe it. It's easy to make this argument from either side. And so we pay a lot of attention to that at my level. And we do it, though, through a slightly different lens. And that is, what does responsible look like? In fact, there's now a coalition for responsible investment in healthcare, actually, that it probably isn't binary. Like the notion of trying to fight all of these is a little bit irrational. And the Oregon bill has already had legal challenges, already trying to kind of weaken it in a couple different areas. But the reality is, why are these folks doing this? Yes, a cheap shot is one answer to kind of generate votes or anger, which generally improves your odds of being elected. But the reality is we've been pretty opaque. So have health systems. You don't know anymore when you go see your doctor whether they're who they're really part of. And so what's the answer? What does reasonable reporting look like? When you sit down with when you sit down with the legislators themselves, they're asking that question. Look, we don't know anything about this. I mean, when you point out, hey, if you do it the way you just designed it, that's going to create a huge bureaucracy. What is it you want to know? How can we make this something that works, that's responsible, so everybody knows? What do we think and let's do that together. That sits really at my level. Inside the organization, though, and I think this all too often gets lost, there are states we prefer not to be in largely because of CON laws, which make it hard for us to do ASCs. And we find those places a little bit irrational just because of how core that is to our value proposition. But other than that, we don't avoid states based on the state law, particularly around things like HSR type responsibilities. Instead, good businesses that have kind of the durability of time and that are doing things the right way are always going to be valuable. And I think over the last 15 to 20 years, particularly in private equity, with the ability to financially engineer a result, I think we lost a little bit of that. And so one of the things we focus on internally is keep your heads down and let's remember what we're trying to do. Let's do that as well as we can. Let's stay engaged. Let's remember what we're trying to do here internally for each other and for our patients. I'll go worry about what's going on at the legislative level and pull people in as we need to. But let's stay focused on that.
With this coalition for the reasonable healthcare policy, are you finding a counterpart that's receptive, a receptive audience, or not so far?
We are, but I still think it's very fragmented
Mhm.
in the sense that, look, everybody prefers the status quo, right? I know how to make money in this environment. It's almost like why aren't physicians gung ho to jump into value based care? Well, when you spend 20 years learning how to do your job and make money at it, the last thing you want somebody to do is go, we're going to quit playing tennis and we're going to play basketball now because it's suddenly a whole different ball game. That piece, you're seeing the wave of influence, the wave of engagement, and the wave of kind of pressure for people to get behind things like this, but it's still pretty fragmented. You've got lobbyists that are very much used to the brass knuckles ball game. The current political environment does not make that easier. And you'll have a legislator tell you privately, look, I get what you're saying and I support it, but if I come out with that, I'll get destroyed in my primary. Those are disheartening things to hear, but it is the political reality right now. And so it's going to take a lot of backroom hand holding, politicking, and working together. What everybody's looking for is the industry to come together and say, hey, we agree. Let's all sit down at a table and figure out what this should look like. And we're not there yet.
Are there things that you're doing at your organization internally to proactively bring transparency to the process? So from a data analytics perspective, perhaps bring transparency to quality, costs, things of that nature?
Absolutely. So that's kind of one of the core of our integrated care clinics and some of our care delivery metrics, what I was alluding to around looking at advanced imaging first in certain care pathways. What does that do to cost of care and quality and outcome? And we're starting to share that data. So that way people can start to see, hey, as we look at this, we're sharing it on an economic basis. The next step here is to publish this on an academic basis. But that's going to be what it takes. It's
And
going to
share with
take
patients, with payers, with legislators, share with who?
mostly with payers and legislators right now, just because that's been the acute issue.
Yeah.
Patients largely aren't asking about that aspect of they care about quality, but the dirty secret of healthcare is quality is assumed until it's evidently not there to a patient. That needs to change as well.
Last question, and we could probably spend another hour on this topic, so I'll take the abbreviated version of it. International healthcare. So you were the founder, CEO, chairman of Neuromatrix, which I believe had a presence in South America as well as Europe. You're on the board of mental virtual care business in the UK. So you have unique vantage point into delivering care beyond the four borders of the US. And you even mentioned USHV potentially considering some international expansion down the road. So would just be curious to hear a quick overview. I know we won't be able to get into tremendous detail on your experience delivering care internationally. What led you to expand beyond the US? Why did it work? What were the challenges? And would you do it again?
Yeah, I think youth and hubris is probably what led us to do it at Neuromatrix. And it was, in many ways at that point in my life, it was fun, it was new, it was exciting, and it was different. What I learned from that is that the problems of healthcare, the delivery, the diagnosis, the treatment, the engagement, and the healing of a patient are universal and don't depend on boundaries. And there is an awful lot we can learn from each other. We used to send our graduate students in neurophysiology, for example, down to South America because they were doing everything as cutting edge as we were, but they were doing it with 1/10 the resources that we had on any given case. And the ability to see that you can have the outcome, that the outcome's not dependent on the extra $1 million we spend in the US on a particular type of neuro case, suddenly begins to shift people's thinking. And it also makes for better clinicians. And so as we've learned that, the second half of that statement now, what I've learned, particularly working in Europe with Helios, which is the mental health company you referred to, European borders look a lot like state borders, as do the rest of the world. There are slight different regulatory, not really as much as you think.
Mhm.
In the US, we have some widely variant regulatory frameworks across the states. Louisiana, they have their own laws. So, when you start to think about it that way, same thing exists in Europe. You do add a language barrier. But when you
Right.
talk about things that technology starts to begin to solve, the language barrier gets very easy to use current technology to start to break down those things and the things that we can teach each other. That's, global health, I think, is coming. It's a time is arriving on the stage. You're seeing large funds like Ares, KKR, and Bain talk about carving out a global health segment. And when you think about the rest of the world, everybody tends to think, well, the market's not as big in the UK, in
Yeah.
India. India is a huge market, but there's not, the per capita income's not there. That's true. But in India, where you have 1 billion people, you still have 50 million people who look a lot like the American market. And so, what I tell people often is maybe don't write it off.
Right.
Think about what you can do because the same problems exist there. And the cost of care, when people do engage it, still follows the same rules. And so we're pretty bullish on that. The right opportunities haven't come for
Yeah.
USHV, but personally, I think global healthcare is one of the ways that we can kind of get past some of the boundaries that we have and
Yeah.
teach each other what we know.
Also, I go back to, the comment you made about the cardiology market with this migration of providers from the hospital to the MSO world. And in some ways that's sort of set the tone of your entire market, right? And so you have this organic growth opportunity and you can afford to focus on building a great business instead of going out and paying a lot of money for an auction process. The impact of having avenues for growth and diversified portfolio growth opportunities sort of changes the culture of a business and changes how you deploy capital. And so maybe these international markets represent another avenue of growth that will allow these organizations to be more patient with their business and really focus on building great businesses rather than, again, just competing at auctions. So
That's well
that's
said.
the more optimistic view.
That's well said.
I'm sure it'll take time, but I'm also equally sure that it will happen, right? You mentioned Hopco earlier. Hopco has a presence in the UK. And so, we are seeing early signs of market leaders that are experimenting. And I'm sure that will continue and increase as the years go by. Robbie, I really want to thank you for this conversation. Incredibly informative, covering a lot of important topics. So I really appreciate the time.
Absolutely. It's always a pleasure. Thank you.
Thanks so much.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.